So without wasting the time, no disclosure, and constrictive pericarditis is a form of diastolic heart failure. It is caused by an inelastic pericardium that inhibits the cardiac filling. The diagnostic modalities which are used for the diagnosis of constrictive pericarditis include echocardiogram, cardiac CT angio, cardiac MRI, and cardiac catheterization. Echo is the preferred initial imaging modality for assessing the pericardial disease, and however, it's less reliable than CMR or CT for pericardial thickening and calcification. However, it's still employed as an initial diagnostic test, and it is recommended by the ACC-AHA. So whenever you are starting echocardiographic examination in a patient with a suspicion of constrictive pericarditis, then you would start with the 2D examination. On 2D, you can appreciate there may be increased echogenicity of the pericardium due to thickening of the pericardium. There may be some degree of pericardial effusion, especially in patients with effusive constrictive pericarditis. And the most important thing on 2D is the septal shudder or septal bounce, which is the abrupt posterior movement of the septum. Then other 2D findings include biatrial enlargement, and again you can appreciate the septal bounce here, and there is IVC dilatation again. The most important finding on M mode is the septal shift, that is the respirophasic septal shift. That is, during the inspiration, the RV would increase, the size of the RV would increase, there will be more freeing of the RV, the septum would move towards the left ventricle, while during the expiration, there will be more filling of the left ventricle and the septum will move towards the right ventricle. So this is ventricular interdependence, and this is more specific for constrictive pericarditis. Then come to the Doppler examination. The Doppler examination of the mitral inflow and tricuspid inflow is important, and again there will be increased E wave. E wave velocity would be increased, and there will be small A wave on mitral inflow as well as the tricuspid inflow. Another important thing on Doppler examination is the marked respiratory variation in mitral and tricuspid inflow velocities. So during inspiration, there will be increased flow across the tricuspid valve. So the tricuspid valve velocity would increase, while during the expiration, there will be more flow across the mitral valve. So mitral inflow velocity would increase. So this is the respiratory variation in mitral and tricuspid inflow velocities. And if it's significant, then it would again signify ventricular interdependence. So these are all signs of ventricular interdependence, which is more important as far as constrictive pericarditis is concerned. The septal shift as well as the respirophasic, septal shift as well as the increased mitral and tricuspid inflow or variation in mitral and tricuspid inflow velocities. So this is an example of mitral and tricuspid inflow velocities, and here you can appreciate that the mitral inflow, there is significant respiratory variation in the mitral inflow velocity, and there is also significant respiratory variation in the tricuspid inflow velocity. Then the other thing which is important is the hepatic vein Doppler. Hepatic vein Doppler करते हुए अक्सर लोग घबराते हैं कि पता नहीं वो क्या है, लेकिन this is just like the pulmonary vein Doppler. उसी तरह से दो forward flow और एक backward flow, and in case of constrictive pericarditis, there will be prominent diastolic flow reversal, especially during expiration. So that's very important that there will be prominent diastolic flow reversal during expiration. Then the important thing is the tissue Doppler examination. The mitral annular velocity by tissue Doppler imaging is a valuable Doppler variable for establishing the diagnosis of constrictive pericarditis, for differentiating it from the restrictive cardiomyopathy. So myocardial relaxation is relatively well preserved in case of constrictive pericarditis. So basically relaxation का problem नहीं है, लेकिन LV को relax नहीं होने दिया जा रहा because of thickened pericardium. So ventricular filling by lateral expansion of the heart is limited because of the rigid pericardium, and the most ventricular filling is accomplished by an exaggerated longitudinal motion of the heart. And the longitudinal motion, hence the mitral septal annular velocity remains preserved or even increased in constrictive pericarditis with higher filling pressures, that is paradoxical to myocardial disease. So although the pressures are increased, but interestingly, the E velocity is supernormal or increased because there is no problem with the diastole. So the longitudinal movement would be increased, so the E velocity would be supernormal. So if the E velocity is increased, mitral inflow is also increased, and the E prime is also increased, then the ratio would be normal. So resulting in normal E to E prime ratio despite elevated LV filling pressures, and this phenomena is termed as annular paradox. कि आपका mitral inflow आपको बहुत बड़ा मिल रहा है, लेकिन आपको E prime भी बहुत बड़ी मिल रही है, and E to E prime ratio is not increased. This is typical for constrictive pericarditis. Another thing is annular paradox. That is high pressure and low E to E prime ratio, and so peak E velocity of more than 8 has a sensitivity of 89% and 100% specificity. So normally the lateral mitral annulus E prime is greater than the septal mitral annulus E prime, but in constrictive pericarditis, lateral E prime is less than the septal E prime, and this is called annular reversus. So annular paradox हमने बात कर ली. Annular reversus is that कि lateral E prime normally ज़्यादा होती है, but in case of constrictive pericarditis, because of the thickened pericardium which is involving the annulus, the lateral E prime would be reduced, and this is called annular reversus. So this is an example of that, and you can appreciate here that the septal E prime is 0.12, while the lateral E prime is 0.08, which is reduced because of constrictive pericarditis. So this is the summary of the echocardiographic findings in a patient with constrictive pericarditis. And मैं जल्दी से quickly इसको revise कर देता हूँ ताकि आप लोगों को take home message कह लीजिए for the juniors. So there is biatrial enlargement, there is septal bounce or septal shudder, there is respirophasic septal shift, and there is increased mitral inflow E velocity, and there is increased respiratory variation in mitral and tricuspid inflow velocities, and their E prime would be supernormal, and the lateral E prime is lower than the medial E prime, and there is diastolic flow reversal in the hepatic vein Doppler during expiration. So this is whole story on the echo. If you see all these findings, then the diagnosis of constrictive pericarditis is very clear to make, but you have to do a comprehensive echocardiographic examination for this thing. So this is again the summary of all these things. And I'm not going to read all these because I have already shown this. So is echo sufficient? Other modalities to add in the diagnosis of constrictive pericarditis include CT, CMR, and cardiac catheterization. So still echo is not perfect, and still there are cases in which the diagnosis is in ambiguity, and then you have to take the help of other imaging modalities, for example, cardiac CT or cardiac MRI. So this is cardiac CT, and cardiac CT में आप, the best thing on cardiac CT is the thickening of the pericardium and the calcification of the pericardium. You can pick up very easily, and you can see other features also, that is biatrial enlargement and things like that. But the pericardial thickness and pericardial calcification आप बहुत अच्छी तरह से देख सकते हैं. Then come to the CMR. CMR is comparable to CT in the assessment of pericardial thickness. It can demonstrate respiratory septal shift in real time image. जिस तरह से वहाँ पर हम कह रहे थे ventricular interdependence आपको respirophasic septal shift से या increased respiratory variation of mitral and tricuspid inflow velocity से मिल रही थी, यहाँ पर आप directly cine images लेकर के without holding the breath, you can see the septal shift during inspiration and expiration. I will show you the image. And also the CMR is helpful in making or ruling out the diagnosis of restrictive cardiomyopathy, but there will be, as there will be specific findings of restrictive cardiomyopathy on CMR. So these are the findings on CMR, and here you can appreciate there is biatrial enlargement, there is thickened pericardium, and there is septal bounce there, but the most important thing is this septal shift, and this is again septal bounce, and again this is the septal shift. So this is the image which is taken without holding the breath. This is the real-time cine image on CMR, and as the diaphragm moves down, it means there is inspiration. So during the inspiration, when the diaphragm moves down, just focus on the septal shift. The septum moves towards the left ventricle. So this is the direct visualization of ventricular interdependence. During inspiration, there is increased filling of the RV, at the cost of decreased filling of the LV. So this is ventricular interdependence. You can appreciate this on CMR very clearly because all other signs on echo or even on catheterization are indirect features, but you are here looking at the direct thing. So another important thing on CMR is the late gadolinium enhancement of the pericardium, which is associated with increased fibroblast proliferation and neovascularization, as well as more prominent chronic inflammation and granulation tissue. So simply आप ये कह सकते हैं, when you do the CMR, you take the late gadolinium images, and if there is late gadolinium enhancement of the pericardium, this indicates inflammation of the pericardium. So whenever there is inflammation of the pericardium, there will be late gadolinium enhancement. So when late gadolinium enhancement of the pericardium is present, the constrictive process is more likely to be inflammatory and modifiable with medical treatment. This is important. So whenever a patient comes to you, you have to first, and with a clinical suspicion of constrictive pericarditis, just go for the echocardiogram with constrictive protocol. If it's diagnostic, then you would like to see whether this is subacute or inflammatory. Then you can, if this is subacute inflammatory, then you can give a trial of medical treatment. If it's not, then you may go for pericardiectomy. And if the echo is not diagnostic, you can take the help of CT or CMR. And if it's diagnostic and if there is delayed enhancement of the pericardium, then you can give a trial of medical treatment. But if there is significant calcification of the pericardium, then you would go for surgery. So quickly, बस दो cases हैं, quickly आपको दिखाते हैं because time is very limited. So a 22-year-old male from Larkana presented with worsening shortness of breath, pedal edema, abdominal distension, and palpitations. He was found to have atrial fibrillation, pedal edema, raised JVP, and ascites, all the features of constrictive pericarditis. So we did the echocardiogram and we found all the features of constrictive pericarditis here. I'm not going to repeat all those, but जो मैंने अभी आपसे discuss किया, all the features were present there. We did the CT angio, and here you can clearly appreciate there is, diffuse calcification. There is thickened and heavily calcified pericardium. So what would be the treatment modality here? Dr. Shahab is sitting here. So this patient was referred for pericardiectomy, and the patient did well after the pericardiectomy. The other patient is a 51-year-old man, presented with few months history of progressively worsening shortness of breath, significant weight loss, and generalized weakness. Initial workup showed massive pleural effusion and some degree of pericardial effusion. He underwent pleurocentesis multiple times with reaccumulation of fluid followed by chest tube insertion, also underwent pericardiocentesis once. So this patient was referred by the surgeon to me, and outside echo was completely normal.
2-minute remaining.
Yeah, so outside echo was completely normal. So there was, reaccumulation of pleural effusion again and again. So we did the echocardiogram, and we find all the findings of constrictive pericarditis. And additional thing was there was suspicion of tuberculoma there. We did so again, all the findings were present there. We did the CMR, and again, all the features in addition to presence of significant pleural effusion there. So this was, again, here you can appreciate the septal shift as well. And then we found also that there is pericardial calcification and possible tuberculoma there. So, pericardial calcification, there is delayed enhancement of the pericardium on late gadolinium images. So here, there was no pericardial calcification, thickening of the pericardium, all the features of constrictive pericarditis, and there is delayed enhancement of the pericardium. So in this patient, we treated the patient with steroids, anti-inflammatory drugs, along with ATT, because the final diagnosis initially made was of TB. So this patient was continued with ATT as well as steroid, and he did well, and the repeat echo showed complete resolution of the features of constrictive pericarditis. So these are the papers which we published during the last few years. पीछे नहीं जा रहा बहरहाल. So we published case series of constrictive pericarditis. So that's all. Thank you very much.